What if the number your doctor circled on that chart and told you was perfectly fine is actually damaging your heart, your kidneys, and your brain right now, quietly, without a single symptom to warn you? And what if the number that sent you rushing to the pharmacy for your first blood pressure prescription was not dangerous at all, but simply a normal physiological response to sitting in a cold exam room with a stranger wrapping a cuff around your arm? I know how contradictory that sounds. But after more than 2 decades of practicing cardiology with a specific focus on adults over 60, I can tell you with absolute certainty that the most dangerous thing about blood pressure is not the number on the screen. It is the widespread, deeply rooted misunderstanding of what that number actually means for your specific body, your specific age, and your specific life. Here is something that should make you stop and think. The Centers for Disease Control reports that nearly half of all American adults have high blood pressure. But when you narrow the focus to adults over 60, the number climbs above 70%. More than 7 out of every 10 people your age are walking around with blood pressure classified as elevated or high. Now here is the part that nobody is talking about. Research from the landmark Framingham Heart Study, one of the most important cardiovascular studies ever conducted, found that risk of heart attack and stroke does not begin at some clearly defined danger threshold. It rises gradually, continuously, starting well below the numbers most people have been told to worry about. The lines on the chart are more arbitrary than most patients realize. So the question is never simply, is my blood pressure too high? The question that actually determines whether you have a heart attack, suffer a stroke, or lose your independence is this: too high for whom? Too high under what conditions? Too high compared to what baseline? And that is exactly what I am going to answer today with real science, real clinical trial data, and the kind of clarity that most patients tell me they have never received from any appointment, any pamphlet, or any previous conversation with a doctor. By the time this is finished, you will understand your blood pressure better than most people ever do. You will know which numbers are genuinely dangerous after 60 based on the largest clinical trials ever conducted on this specific population. You will know about a hidden third number, one that most doctors never calculate and almost never mention, that predicts your risk of heart attack and stroke more accurately than either the top or the bottom number alone. And you will know the measurement mistakes that are giving millions of Americans completely false readings and leading to treatments that are either unnecessary or dangerously insufficient. I am a cardiologist who has spent more than 20 years focused almost entirely on cardiovascular health in adults over 60. I have sat across from thousands of patients who were confused, frightened, and frustrated, told by one doctor their numbers were fine and by another that they needed more medication immediately. Patients who were over-medicated and falling down because their blood pressure was pushed too low. Patients who were under-medicated and quietly marching toward a stroke because their true pressure was never measured correctly. The confusion is never their fault. Guidelines have changed multiple times over the past 20 years. Numbers considered perfectly safe a generation ago are now recognized as dangerous. And the way most people measure blood pressure, both at home and in clinical offices, produces readings that are far less reliable than anyone is being told. Today, I am clearing all of that up. Let us begin with the foundation, because until you understand this, everything else about blood pressure will remain confusing, no matter how many times someone explains it to you. Your blood pressure reading has 2 numbers. Most people pay attention primarily to one of them. That is the first and most common mistake. And it is a mistake I have personally seen contribute to outcomes that were entirely preventable. The top number is called systolic pressure. This is the force your blood exerts against the walls of your arteries at the exact moment your heart contracts and pushes blood out into circulation. Think of it as a wave. Every single heartbeat sends that wave crashing through your vascular system. The intensity of that wave, the force it hits with, is your systolic pressure. The bottom number is called diastolic pressure. This is the pressure that remains in your arteries between heartbeats, in the moments when your heart relaxes and refills before squeezing again. Think of it as the background tide level, the constant underlying pressure your blood vessel walls are living with every second of every day, even when your heart is resting between beats. Both numbers matter, but after 60, they do not matter equally. And understanding why is one of the most clinically important things I can give you today. As you age, your arteries undergo a fundamental physical change. They stiffen, they lose the elasticity and flexibility they had in younger decades. When arteries are stiff, the wave from each heartbeat hits the vessel walls with far greater force because those walls cannot expand and absorb the impact the way they once did. This is why systolic pressure, the top number, tends to rise as we age. It is not always a sign of disease. Sometimes it is simply the physics of older, stiffer blood vessels responding to the same heartbeat with greater pressure than a younger, more flexible vessel would generate. But the bottom number often does something completely different and frequently opposite. As arteries lose their ability to recoil and spring back between beats, diastolic pressure often stays the same or actually decreases after 60. This creates a pattern that is extremely common in older adults and that most people have never had explained to them clearly. It is called isolated systolic hypertension. The top number rises, the bottom number stays the same or drops, and the gap between them widens. This is the single most common form of high blood pressure in adults over 60, and it carries risks that are different from the kind of hypertension that affects younger adults. Here is where the confusion becomes genuinely dangerous. For decades, physicians were taught a simplified rule of thumb. Normal systolic pressure equals 100 plus your age. Under that formula, a 72-year-old with a systolic reading of 172 was considered entirely within normal range. That rule was wrong. It was based on observation rather than outcome data, and it cost an incalculable number of lives. We now know from rigorous clinical trial data that sustained systolic pressure of 170 or above in a 70-year-old significantly elevates the risk of stroke, heart failure, kidney damage, and cognitive decline. That old formula gave millions of people false reassurance while their organs were being silently damaged year after year without a single warning sign. But the pendulum swung too far in the other direction. In 2017, the American College of Cardiology revised its definition of high blood pressure downward to 130/80. Overnight, tens of millions of previously normal American adults were reclassified as hypertensive. A very large proportion of them were over 60. Many felt completely well. Many were started on medications whose benefit in their specific situation was, at best, modest, and at worst, introduced new risks that outweighed the benefit of the medication itself. The recategorization was scientifically motivated, but it was applied with a broadness that created enormous confusion and, in many cases, real harm through overtreatment. So what is genuinely too high after 60? What does the best available science actually say? The most important study addressing this specific question is the SPRINT trial, published in the New England Journal of Medicine in 2015. More than 9,300 participants, the largest and most rigorous blood pressure treatment trial ever conducted in this population. SPRINT found that targeting systolic pressure below 120 reduced the combined risk of heart attack, stroke, and cardiovascular death by 25% compared to the traditional target of below 140. In adults over 75 specifically, the benefit was even more dramatic, a 33% reduction in major cardiovascular events. That is an extraordinary finding. It is one of the most significant results in the history of blood pressure research. But the SPRINT trial also found something that gets far less attention when the results are discussed. Aggressive treatment to reach that lower target came with real and significant costs. More episodes of fainting and dizziness, more dangerous electrolyte imbalances, more kidney complications, and more falls. In adults over 60, particularly over 75, a fall caused by blood pressure that has been pushed too low by aggressive medication can be just as life-threatening as the elevated pressure the medication was intended to treat. A hip fracture in a 78-year-old carries a one-year mortality rate of approximately 20 to 30%. That is not a minor side effect. That is a potentially fatal consequence of overtreatment. This means there is no single number that is too high for every person over 60. The right target is not written on a chart. It depends on your age, your overall health, your specific risk factors, your history of falls, your kidney function, and frankly, how your body responds to the medications used to get there. But I can give you the specific ranges that the research supports, calibrated for age and circumstance, because that kind of clarity is what most patients tell me they have never received. For adults between 60 and 75, a systolic pressure below 130 at rest is ideal and is associated with the best long-term outcomes. Systolic between 130 and 139 is acceptable if you feel well, have no other major risk factors, and your lifestyle supports cardiovascular health. Systolic between 140 and 149 needs monitoring, lifestyle intervention, and a serious conversation with your doctor about whether medication is appropriate in your situation. Systolic at 150 or above consistently at rest is too high. That is a number that needs action, not observation. For adults over 75, the calculus shifts somewhat because of the fall risk I just described. Below 140 is the general goal, and it is achievable for most people with the right approach. Between 140 and 149, the decision depends heavily on how you feel, your history of falls or dizziness, and your overall cardiovascular risk profile. At 150 or above consistently, that is too high regardless of age. The risks of sustained elevation at that level outweigh the risks of careful treatment in virtually every case. For diastolic pressure, the number that receives far less attention than it deserves, below 80, is ideal at any age over 60. Between 80 and 89 warrants monitoring and lifestyle attention. At 90 or above consistently, that level of diastolic pressure places significant and ongoing strain on arteries and organs that is not sustainable without eventual damage. Now I want to give you something that I genuinely believe is one of the most valuable pieces of cardiovascular information available to someone over 60, and it is something that most physicians never calculate during an office visit, never explain to patients, and never mention in the context of risk. It takes 5 seconds to calculate from any blood pressure reading you already have. It is called pulse pressure, and the research shows it predicts heart attack and stroke risk more accurately than either the top or bottom number alone in adults over 60. Pulse pressure is simply the difference between your systolic and diastolic numbers. If your reading is 150 over 70, your pulse pressure is 80. If your reading is 130 over 80, your pulse pressure is 50. That is it. The math takes 5 seconds, but what it reveals is something far more important than the individual numbers. Pulse pressure is a direct measurement of arterial stiffness. When arteries stiffen with age, they push the systolic number higher because they cannot absorb the impact of each heartbeat, and they let the diastolic number drop lower because they cannot recoil effectively between beats. The gap between the two numbers widens, and that widening gap is one of the clearest and most reliable cardiovascular danger signals we have in older adults. A landmark analysis using Framingham Heart Study data, published in the journal Hypertension, found that pulse pressure was a stronger predictor of cardiovascular events than either systolic or diastolic pressure alone in adults over 60. Let me be precise about what that means. Not stronger than systolic alone or diastolic alone in some marginal statistical sense, meaningfully, clinically stronger. The gap between your numbers tells you more about your cardiovascular future than either number by itself. Here is how to interpret your pulse pressure. Below 40 is normal and indicates healthy arterial flexibility for your age. Between 40 and 60 is acceptable but worth monitoring, particularly if it is trending upward over time. Above 60 is a warning sign of significant arterial stiffness and substantially elevated cardiovascular risk. If your reading is 165 over 70, most people and many doctors focus their attention on the 165. But your pulse pressure is 95. That is not a warning sign. That is an alarm. It indicates that your arteries have lost critical flexibility, that your heart is working dangerously hard against stiff resistance with every single beat, and that your cardiovascular risk extends well beyond what the systolic number alone would suggest. Calculate your pulse pressure today from whatever reading you have. It will tell you something important about your cardiovascular health that you have almost certainly never been told before. Now, I want to address something that almost never comes up in conversations about blood pressure in older adults, something that I consider just as important as identifying pressure that is too high. It is diastolic pressure that has been pushed too low, and this is a danger that is hiding in plain sight in the blood pressure readings of older adults across the country right now. In older adults, diastolic pressure below 60 is genuinely dangerous. A study published in the Journal of the American College of Cardiology found that adults over 60 with diastolic pressure consistently below 60 had significantly increased risk of myocardial infarction, heart attack, because the pressure between heartbeats was insufficient to adequately supply the heart muscle itself with blood. Your coronary arteries, the vessels that feed your heart, fill primarily during diastole, the relaxation phase between beats. If diastolic pressure drops too low, your heart muscle is not getting adequate blood flow, even while it is busy pumping blood to the rest of your body. That is a dangerous and underappreciated situation. I treated a patient, a 76-year-old retired engineer who had been on 3 blood pressure medications for several years. His systolic was beautifully controlled at 126. His doctors were pleased, but his diastolic had drifted down to 54 over the same period, and nobody had flagged it as a problem. He was dizzy every time he stood up from a chair. He had fallen twice in 6 weeks. He came to me not because of blood pressure concerns, but because his primary care physician wanted him evaluated for a balance disorder. There was no balance disorder. His diastolic pressure was so low that his heart was not receiving adequate perfusion between beats, and his body could not compensate fast enough when he changed positions. We carefully reduced one of his 3 medications over several weeks. His diastolic rose to 66. The dizziness resolved completely. The falls stopped. His systolic remained controlled. He was not sicker than before. He had been over-medicated, and nobody had noticed because everyone was watching the top number. Do not only watch the top number. Do not only watch the bottom number. Calculate the gap between them and know your pulse pressure. And make sure the bottom number has not been pushed below 60 by treatment that is well-intentioned but insufficiently monitored. Too low is not safe. Too low has its own risks. And in older adults, those risks are serious. Let me ask you something directly. Do you know your blood pressure right now? Not from a reading weeks or months ago. Right now, today. And have you ever calculated your pulse pressure? Have you ever looked at that gap and understood what it was telling you about the flexibility of your arteries and the effort your heart is making with every single beat? Go to the comments and tell me your numbers. I read every comment on these videos personally, because the conversation that happens in the comments matters as much as the video itself. Now, I am going to show you something that has enormous practical implications for every person watching this. The measurement mistakes that are giving millions of Americans completely wrong blood pressure readings. These are not minor errors that shift numbers by a point or two. These are systematic mistakes that can add 10, 20, even 30 points to your reading. And those false points are sometimes the entire difference between going home without a prescription and leaving the pharmacy with a medication you will be told to take for the rest of your life. The first mistake is measuring without adequate rest beforehand. You walk into a medical office, check in at the front desk, walk down a corridor, sit on an exam table that crinkles paper under you, and within 90 seconds, someone wraps a cuff around your arm. That reading is almost certainly not your true resting blood pressure. Research published in the journal Hypertension found that blood pressure taken without a minimum of 5 minutes of quiet sitting rest was 10 to 15 points higher systolic than readings taken after proper rest. That single difference, 10 to 15 points, is the gap between a reading of 135 and a reading of 150. It is the gap between monitoring and medicating in many cases. And it happens in virtually every clinical office in the country every single day. The second mistake is talking during the measurement. This seems trivial. It is not. Research in blood pressure monitoring found that conversation during cuff inflation raised systolic readings by 10 to 15 points. The medical assistant takes your cuff reading while asking you about your current medications or how your weekend was. You answer. The reading is immediately falsely elevated. Nobody in the room connects the conversation to the number on the screen. The third mistake is crossing your legs during measurement. The same research found that crossing one leg over the other during blood pressure measurement raised systolic readings by 5 to 8 additional points. Now add those 3 mistakes together. No rest before measurement. Talking during the reading, legs crossed on the exam table, you have potentially added 25 to 35 points to your true resting blood pressure before a single clinical decision is made. That is not a measurement. That is a guess. And it is a guess that is systematically biased upward. The fourth mistake is using the wrong arm or the wrong cuff size. Blood pressure readings frequently differ between the left and right arm by 5 to 10 points or more. If you always measure the same arm, you are getting a systematically skewed picture. A cuff that is too small for the circumference of your arm inflates readings artificially and significantly. This is almost never checked or corrected in clinical settings, but it is an extremely common source of false elevation, particularly in patients whose arm circumference has increased over time. The fifth mistake is one that is both the most significant and the least discussed. It is called white coat hypertension. This is the phenomenon of blood pressure rising specifically in a medical setting, driven by anxiety that you may not consciously experience, but that your nervous system generates automatically. Your body does not distinguish between anxiety you recognize and anxiety that occurs below the threshold of conscious awareness. When you enter a medical environment, your sympathetic nervous system responds, heart rate increases, adrenaline releases, blood pressure rises. A comprehensive meta-analysis published in the journal Hypertension found that white coat hypertension affects between 15 and 30% of adults diagnosed with high blood pressure. Up to 1 in 3 people currently being treated for hypertension may not actually have hypertension at all. Their pressure is only elevated when measured by someone in a clinical setting. And yet, many of them are on daily medications with real side effects based entirely on readings that reflect anxiety rather than true cardiovascular disease. This is why home blood pressure measurement is not optional. It is essential, but it is only valuable if it is done correctly. And the protocol that produces accurate, reliable, clinically meaningful readings is almost never taught properly. Here is the protocol I give every patient I see over 60. Before you touch the cuff, sit quietly for a full 5 minutes, not 4 minutes. 5. Feet flat on the floor, back fully supported against the chair, no leaning forward, arm resting at heart level on a table or armrest, bladder empty because a full bladder can raise blood pressure by 10 to 15 points on its own. No talking, no phone, no television, no reading, just 5 minutes of quiet sitting. Then take 2 readings 1 minute apart. Record both, use the lower of the 2, write it down with the time and which arm you used. Do this twice daily, once within 20 minutes of waking in the morning, before coffee, before breakfast, before any medication, and once in the evening before bed. Alternate which arm you use every other day. Do this for 7 consecutive days. You will have 28 readings. Average all of them. That average is your true resting blood pressure. Not a single office reading taken after you walked through a parking lot and answered questions while someone inflated a cuff on your arm. Your actual cardiovascular baseline, measured under conditions that give it the best possible chance of being accurate. If that 28 reading average is consistently above 150 systolic, that is too high and needs attention. If it is consistently between 130 and 149, bring that log to your doctor. Those 28 numbers are worth more than any single exam room reading that has ever been taken from you. They are a clinical picture rather than a snapshot. And a clinical picture is what drives good decisions. I want to spend time on something that I know from years of clinical experience creates enormous anxiety for patients over 60. It is the question of when a high blood pressure reading is a medical emergency requiring immediate action, and when it is a spike that can be safely managed at home with rest and monitoring. Most people have never been given a clear and reliable answer to this question. And the absence of that answer leads either to unnecessary panic that results in costly and often traumatic emergency room visits, or dangerous complacency that leads people to wait when waiting could be fatal. Here is the foundational principle that will clarify everything. A high number by itself, even a very high number, is not automatically a medical emergency. I understand why that sounds counterintuitive, but blood pressure is not static. It fluctuates throughout every day and every person. It rises with physical activity, emotional stress, pain, caffeine, cold temperatures, a full bladder, and even the act of checking it. It is entirely possible to have a genuine resting blood pressure of 130 and a momentary reading of 175 30 minutes after an argument or a stressful phone call. Those 2 readings exist in the same body on the same day. They do not represent the same physiological state. The factor that distinguishes a spike from a crisis is not the number. It is the presence or absence of symptoms. A high number without symptoms is a signal to rest, recheck, and monitor. A high number accompanied by specific symptoms is a signal to seek emergency care without delay. Here are the symptoms that transform an elevated reading into a medical emergency. If your blood pressure is above 180 systolic or above 120 diastolic and you experience any of the following, you should call emergency services immediately and not drive yourself. A sudden, severe headache that is unlike any headache you have experienced before. Chest pain, pressure, or tightness of any kind. New or worsening shortness of breath that is not explained by physical exertion, vision changes including blurring, partial vision loss, or sudden visual disturbances, difficulty speaking, sudden confusion, or trouble finding words, numbness or weakness on one side of your body, in your face, arm, or leg. These symptoms indicate what we call hypertensive crisis, a state in which blood pressure is actively damaging organs in real time, including the brain, the heart, the kidneys, and the retinas. This is a true emergency. Minutes matter in a way that is not metaphorical. Research published in the journal Circulation found that hypertensive crisis carried a mortality risk approaching 25% within the first year when not treated promptly and appropriately. 1 in 4 people who experience hypertensive crisis and do not receive timely treatment do not survive the year that follows. That is a statistic that deserves to be taken seriously. But here is the other side of that equation, which is equally important. If your reading is 172/96 and you feel completely normal, no headache, no chest discomfort, no vision changes, no neurological symptoms, that is not a medical emergency. That is what we call a hypertensive urgency. The medical distinction matters enormously. Sit down in a quiet space. Rest for 5 full minutes. Breathe slowly and deliberately, extending your exhale to be longer than your inhale, which activates the parasympathetic nervous system and begins to lower pressure. Retake your reading after 10 minutes of genuine rest. In the overwhelming majority of cases, the number will drop significantly, often by 20 to 30 points, simply through the act of resting and intentional breathing. A patient I saw several years ago, a 70-year-old retired high school teacher, called our office in genuine distress. Her home monitor had read 185/100. She was already putting her coat on to drive herself to the emergency room. I asked her 3 specific questions before she left. Did she have a headache? No. Any chest pain or pressure? No. Any vision changes or difficulty speaking? No. I asked her to sit down, put the phone on speaker, close her eyes, and breathe slowly for 10 minutes. Then retake the reading and call me back. 14 minutes later, she called. The reading was 146/88, still elevated compared to her baseline, but not crisis territory, not emergency room territory. She had just come off a call with her insurance company that had lasted 45 minutes and ended in complete frustration. Her nervous system had flooded with stress hormones. Her blood pressure had spiked acutely and temporarily in a way that her body was already beginning to resolve on its own. Her true blood pressure was never 185. Her stress-reactive blood pressure was 185. Those are 2 different physiological events, and they require 2 different responses. This is the clinical lesson that most patients never receive, but that has the potential to prevent enormous unnecessary suffering. We do not diagnose and we do not treat single spikes. We identify and treat patterns. 1 high reading is a data point. 2 weeks of consistently elevated readings is a pattern. A reading of 190 with a crushing headache and numbness in one arm is an emergency, regardless of what the baseline pattern looks like. Know the difference between these categories, know which symptoms require immediate emergency response, and know that a single high number on a screen in the absence of those symptoms is a reason to rest and recheck, not a reason to panic. Both kinds of errors, overreacting to a spike and underreacting to a genuine crisis, carry serious costs. The knowledge to distinguish between them accurately is something every person over 60 deserves to have. I want to take a moment to address something that rarely comes up in medical discussions about blood pressure, but that I believe is among the most important factors influencing cardiovascular readings in older adults. It is the relationship between blood pressure and the nervous system, specifically the role that chronic psychological stress plays in sustained blood pressure elevation. Most discussions about blood pressure focus on diet, exercise, weight, medications, and genetics. These are all legitimate and important factors, but chronic activation of the sympathetic nervous system, the fight or flight branch of your autonomic nervous system, maintains blood pressure elevation in a way that is often underestimated and frequently undertreated. When you are under sustained psychological stress, whether from caregiving responsibilities, financial concerns, social isolation, sleep disruption, or unresolved grief, your body maintains elevated cortisol and adrenaline levels that keep blood pressure higher than it would otherwise be, not in dramatic spikes, in a persistent low-level elevation that accumulates damage over months and years. The research on this is substantial. A meta-analysis published in the Journal of the American Heart Association found that interventions targeting psychological stress, including mindfulness-based stress reduction, were associated with clinically meaningful reductions in systolic blood pressure in older adults. Meaningful enough, in some cases, to eliminate the need for a first medication or reduce the dose of existing medication. This is not alternative medicine. This is established cardiovascular science. The nervous system is a major driver of blood pressure, and managing its activation level is a legitimate and evidence-supported component of blood pressure management. Slow, deliberate breathing, specifically breathing that extends the exhale to approximately twice the length of the inhale, activates the vagus nerve and the parasympathetic system, directly counteracting the sympathetic activation that drives pressure upward. 5 minutes of this kind of breathing, done consistently twice daily, has been shown in controlled research to produce measurable reductions in resting blood pressure over time. It is not a replacement for medication when medication is clinically indicated, but it is a tool of real power that costs nothing and has no side effects, and almost no one is told about it during a standard blood pressure appointment. Sleep is the other deeply underappreciated variable. Blood pressure follows a predictable pattern in healthy adults, dropping by 10 to 20% during nighttime sleep in what is called the nocturnal dip. Adults who do not experience this dip, who are called non-dippers in the research literature, have significantly higher rates of cardiovascular events than those whose blood pressure follows the normal nocturnal pattern. Poor sleep disrupts this dip. Sleep apnea, which is remarkably common in adults over 60 and frequently undiagnosed, not only disrupts the nocturnal dip, but actively drives blood pressure upward through repeated cycles of oxygen deprivation and adrenaline release throughout the night. If your blood pressure is elevated and your sleep is poor, those two facts are very likely connected. Addressing the sleep problem is addressing the blood pressure problem. Dietary sodium is a factor that every blood pressure conversation touches on, but the nuance is often lost. Not everyone is equally salt sensitive. Approximately 50 to 75% of older adults with hypertension are salt sensitive, meaning their blood pressure responds meaningfully to sodium intake. For them, reducing dietary sodium produces clinically significant reductions in blood pressure. For the remaining 25 to 50%, sodium reduction has minimal effect. The problem is that without knowing which group you belong to, you cannot know whether the effort and dietary restriction of a low-sodium diet is producing meaningful benefit or is simply an uncomfortable sacrifice with modest cardiovascular returns. A simple way to gain some insight is to track your blood pressure carefully for 2 weeks of your typical eating pattern, then track it again over 2 weeks of meaningfully reduced sodium intake. If your average drops by 5 or more points systolic, sodium is a significant factor for you. If it does not move, your blood pressure is likely driven more by other factors, and the energy of dietary intervention is better directed elsewhere. Potassium is the dietary factor that is dramatically underemphasized relative to sodium. Potassium works through a complementary mechanism to sodium in blood pressure regulation, and the research consistently shows that increasing potassium intake reduces blood pressure in hypertensive adults at least as effectively as equivalent reductions in sodium, and sometimes more effectively. Potassium-rich foods include leafy green vegetables, beans and lentils, avocado, sweet potatoes, bananas, and salmon. Most adults over 60 are not eating enough of these foods consistently, And while potassium supplementation requires medical supervision, particularly in adults with kidney disease or who take certain blood pressure medications, increasing potassium through whole foods is safe for virtually everyone and has benefits that extend well beyond blood pressure. Physical activity is the blood pressure intervention with perhaps the most robust evidence base and the most consistently overlooked clinical potential. A meta-analysis of more than 390 randomized controlled trials found that structured aerobic exercise reduced systolic blood pressure by an average of 4 to 9 points in hypertensive adults. That is comparable to the effect of a first-line antihypertensive medication. And the benefits are additive to medication. Exercise and medication together produce greater reductions than either alone. The type of exercise matters less than the consistency. Walking briskly for 30 minutes 5 days a week produces meaningful cardiovascular benefit. Resistance training 2 to 3 times weekly adds additional benefit through independent mechanisms. For adults over 60 who are concerned about blood pressure, the recommendation to exercise more is not generic wellness advice. It is a specific, evidence-supported clinical recommendation with a dose and a mechanism and an expected outcome. Let me now bring everything together in a way that I hope gives you not just information, but a clear framework for thinking about your own blood pressure in the context of your own life. You now understand that your blood pressure reading has 2 numbers that tell you different things and that behave differently as you age. The top number, systolic, reflects the force of each heartbeat against your arterial walls and tends to rise with age as arteries stiffen. The bottom number, diastolic, reflects the pressure between beats and may stay the same or drop. The gap between them, your pulse pressure, tells you something about arterial stiffness that neither number alone can convey. You know the ranges that the research supports. For adults, 60 to 75, systolic below 130 is ideal. Between 130 and 139 is acceptable in the right circumstances. Between 140 and 149 needs monitoring and likely intervention. At 150 or above consistently, that is too high and needs action. For adults over 75, below 140 is the goal. At 150 or above consistently, that is too high regardless of overall health status. Diastolic below 80 is ideal. Between 80 and 89 warrants attention. At 90 or above consistently, the strain on arteries and organs is clinically significant. You know that pulse pressure, the simple subtraction of your diastolic from your systolic, predicts cardiovascular risk more accurately than either number alone in adults over 60. Below 40 is normal. Between 40 and 60 warrants monitoring. Above 60 is a warning signal of arterial stiffness and elevated cardiovascular risk that should not be ignored. You know that diastolic pressure that is too low, consistently below 60, carries its own serious risks, particularly regarding blood supply to the heart muscle itself between beats. Overtreatment that pushes the bottom number too low is not safe. It is a different kind of dangerous. You know the 5 measurement mistakes that routinely add 25 to 35 false points to readings. No rest before measurement. Talking during the reading. Crossed legs, wrong arm or inadequate cuff size. And white coat hypertension affecting potentially 1 in 3 people currently on blood pressure medication. You know the correct measurement protocol. 5 minutes of quiet rest, feet flat, back supported, arm at heart level, 2 readings 1 minute apart, use the lower, twice daily, 7 consecutive days, 28 readings, 1 average. That is your true baseline. You know the distinction between a blood pressure spike and a hypertensive emergency. Elevated number without symptoms means rest, recheck, and monitor. Elevated number above 180 systolic or 120 diastolic with severe headache, chest pain, vision changes, difficulty speaking, or one-sided weakness means call emergency services immediately without waiting and without driving yourself. And you know that blood pressure management extends well beyond the prescription pad. Nervous system regulation through deliberate breathing and stress management. Sleep quality and the identification and treatment of sleep apnea, dietary patterns that support potassium intake and appropriate sodium reduction in those who are salt sensitive, and consistent physical activity at a level that the research shows is as effective as medication in reducing blood pressure. In more than 20 years of cardiology practice, the most consistent finding I have encountered is not that patients are failing to take their medications or ignoring their numbers. It is that patients who understand their numbers, who understand what those numbers mean and what influences them, consistently make better decisions, experience less unnecessary anxiety, avoid more unnecessary treatments, and ultimately have better outcomes than patients who are simply told what number is too high without ever being given the framework to understand why. Understanding your blood pressure does not create fear. It removes the specific kind of fear that comes from not understanding. It replaces helpless anxiety with grounded knowledge and the ability to act appropriately when action is called for and to rest appropriately when rest is what the situation requires. What is your blood pressure today? What is your pulse pressure? If you do not know those numbers right now, I want to encourage you to take a reading this evening using the protocol I described. Calculate the gap. Write it down, and come back to the comments to share what you found. That 5-second calculation might tell you something about your cardiovascular health that no office visit has ever communicated clearly. If this gave you clarity about something that has been confusing or frightening, share it with someone you care about who is over 60 and who is ever worried about their blood pressure numbers. Because clarity, the real kind, is not something people find easily in a standard 15-minute medical appointment. And everyone deserves to understand what their body is telling them. Blood pressure is not a verdict. It is a signal. And now you know how to read it. This video is for educational purposes only and does not constitute medical advice. Please consult your physician before making any changes to your medications or health management routine.